Good afternoon and happy American Heart Month, everybody. As we observe this special time of year to recognize and celebrate our professionals and patients, I'd like to share a few special announcements. First, I'd like to congratulate Dr. Egelam, Angela Lewis, and Dr. Saeed and all those involved with the Cardiovascular Fellowship Program for being awarded full accreditation by ACGME. So congratulations to them and us. I'm also super excited to share that registration for the 3rd annual Georgia Heart and Vascular Symposium is now open. You can go to georgiaheartinstitute.org/symposium for the agenda and registration. And again, this year, employees get to attend for free. So if you could go to Connect, you in the search bar, search for Georgia Heart and Vascular Symposium. There you will find a flyer with the employee-only discount code. If you have any questions, you can always feel free to reach out to me, Suzanne McNeil. Please also watch for messaging about upcoming grand rounds and the Valentine celebration that will be on February 14th. So diving into our program today, we welcome guest speaker, Dr. Edward Chen, Professor of Surgery at Duke University. Also, Drs. Guy and Hastings will present cases with us. The planners and Dr. Chen have disclosed no relevant financial relationships with commercial interests. To claim credit today, take our online survey, and that link will be shared in the chat and at the end of today's program. If you have a question for the presenter, please hold until the Q&A segment. And now, let's welcome Dr. Hastings, who will introduce Dr. Chen.
Thank you all, and I appreciate you all being here. It's quite an honor to have Dr. Chen with us today. I was going to try to wing his introduction, but there's too much here and I'm going to mess it up. So I'm going to actually use my notes and give a proper introduction for Dr. Chen. Edward P. Chen, MD, is a professor of surgery at Duke University. He is a graduate of Stanford University, Duke Medical School, University of California, San Francisco General Surgery, as well as Emory Cardiothoracic Surgery Residency and the University of Texas Houston Aortic Surgery Fellowship. He is internationally visible for his clinical expertise in reoperative thoracic aortic procedures, high risk, and complex adult cardiac surgery. He's published over 250 peer-reviewed articles, and his research has focused on cerebral protection for aortic artery construction, aortic root operations, aortic dissection, and valve-sparing aortic root replacement. He has been a PI and co-PI on numerous clinical trials focused on thoracic aortic surgery and structural heart disease. He has won awards for both his research and commitment to teaching, including the Thoracic Surgery Residents Association Socrates Award in 2019, the European Association for Cardiothoracic Surgery at Society of Thoracic Surgery's Research Awards 4 times, 2017, 2018, 2020, and 2021. Also, the American Association for Thoracic Surgery Aortic Symposium 2018 Greek Research Award and Outstanding Teacher in Cardiothoracic Surgery at Emory numerous times, 2007, 2009, and 2010. Dr. Chen has held several leadership positions in the AATS, including the Cardiothoracic Resonance Committee, the Annual Meeting Didactic Committee, Chair of the Aortic Cardiac Skills Course, the Ethics Committee, Chair of the AATS Foundation Travel Awards Committee, Association Advisory Council on Education, the Aortic Symposium Program Committee, AATS Cardiac Clinical Practice Writing Group of Aortic Type A Dissection, Aortic Cardiac Education Committee, the Foundation Advisory Council, and co-chair of the IT Committee. His leadership positions in the STS include the STS Workforce of Adult Cardiac and Vascular Surgery, as well as co-chair of the STS Aortic Surgery Database Task Force. He's also on the American Heart Association and ACC Aortic Guidelines Writing Committee, the AHA ACC Valvular Heart Disease Performance Measures Writing Committee, and the EACTS Aortic Disease Guideline Writing Committee. So all of the guidelines and pretty much we all abide by and deal with. This is the man that has helped author all of those things. So we are honored to have you, Dr. Chen. Please come forward.
Thanks very much, Clifton. It's certainly a privilege for me to be here today. I think and the one thing that Clifton did not mention, that I'm a proud son of this state. I was raised in this state from age 3 to high school, and then lived for 21 years as an adult here. So, always good to come back to Georgia. Certainly it has been and always will be home for me. As a cardiac resident and faculty at Emory, I've always admired and heard a lot of great things about Northeast Georgia and the health system here. And one of the things that was really great for me over the last couple of days to see was not only the dedication to what you guys do here, the dedication to high quality, innovative patient care, but more importantly, the manner in which it's being done, i.e. professionalism, collegiality, a supportive environment, one of respect, for all team members. So it's really great for me to be here. I wanted today to talk a little bit about, introduce you to sort of who I am, my career, and just tell a story a little bit about, what I've done in my career, my path in academic medicine, share some of the core values that I hold as a physician, and pass on some important lessons I've learned during my time as a faculty member. So even though I was raised in Georgia, my parents are from Taiwan. I was born in Tokyo when they were in grad school, and then lived there for about a year, and then went to Taiwan to live with my grandparents for about a year when my parents were in Yale my dad was doing a postdoc in forestry. Ultimately, they decided to settle in the United States. So I spent a year between Yale and Seattle. And then when I was 3 years old, we moved to Atlanta for about 3 years. My dad worked at Georgia Pacific and then took a job at the University of Georgia. So from age 6 through 18, I was raised in Athens, Georgia. So if any place is my hometown, it's Athens, Georgia. I went to Stanford for undergrad, then Duke, and all these other places that you see. And so here I am now. But, I think, professionally, I was on faculty at Emory, for 21 years, and then been at Duke for about 3 years now. And my primary clinical focus has been adult cardiac surgery, thoracic aortic surgery, mostly open reconstruction, valvular heart disease, mostly just embraced and high-risk complex operations. I think, at the time, in the early 2000s, that was kind of what was being taken care of at a tertiary medical center. So when Dr. Salmon and his colleagues called me, really, if we didn't do those cases, there's nothing else to do. So we just took them on, and fortunately we had good results and so forth. But, just to kind of share with you this is a patient here in the upper right. This is a patient that had a Ross procedure, then developed an aneurysm of the autograft. So we went and did a valve sparing on the Ross, and this is a hole in the RVOT because the pulmonary homograph was calcified. So we had to do an RVPA conduit and then the valve sparing here. This was just a guy that had an arch aneurysm, needed a total arch, and you see the 3 branches. This particular patient was a Marfan patient operated on by Joe Caselli, had a homograph root, and then he came back with a calcified root and a dissection in his proximal aorta. We did a redo root, total arch, and then he needed a descending, which we did down to about here. Then all this ballooned up, and we ended up just finishing it all with all the branches to the viscerals. And he had aneurysm enlargement down to the bifurcation. So we had to implant both of those, the iliac separately. But I've always tried to pursue excellence in surgery and academic medicine, and I was hired to develop an aortic surgery service line, and I was fortunate to have gained visibility based really on the ability to do the complicated case, the impossible case, participating in education and scholarly activity, and really completely committed to teaching the next generation. Before I came to Duke, we did have a service line, and they still do, of treating all types of thoracic and abdominal pathology, elective, emergent, open, endovascular. We enjoyed collaboration between our vascular colleagues, our cardiology colleagues, both adult and congenital, our genetic specialists, as well as our radiology colleagues. And we had expertise in high-risk surgery, endovascular treatment of acute and chronic dissections, branched and fenestrated repair of thoracoabdominal aneurysms. And our annual CT volume in our division was about 350 cases. Our type A dissection mortality was about 2.5 times lower than the worldwide reported mortality. We started treating endovascular. We started applying endovascular treatment with complicated type B. Our elective proximal aortic cases. It was around 2%. Anyone that needed an arch, ascending root, AVR, up to the subclavian, first-time elective surgery was about 2% mortality. And then we recently had good thoracoabdominal results. But we took all that great clinical work and parlayed it into, research, and we're given multiple talks and wrote a lot of papers. And then, as Dr. Hastings said, we were fortunate to have won several awards. But most importantly, we were able to provide great education for our residents. I think I did like 10 aortic cases during my time as a chief resident. And I think Dr. Harrington finished in 17 or so. He did 60 of those cases with us, St. Joe's, about 70 total during his time. And then we had a fellowship that we started, non-ACGME fellowship in 2017. So how did all that happen for me? Well, and when I got to Emory in 2000, it was one of 4 hospitals performing cardiac surgery within the Emory system, along with Grady, the VA, and Crawford Long, and now Emory Midtown. Most of the cases were from outside Atlanta, for mostly cabbages. And at Emory Hospital, there's 2 surgeons that had been on faculty since the early 70s. And this was a referral pattern back then. And as high quality cardiac surgery went into the community, each of these places that used to send cases to Atlanta, including, Gainesville here, they didn't need to do that anymore. So over time, the cardiac volume decreased, and it was one of those situations where there was a lot of concern, and that was, a changing landscape in cardiac surgery. And sometime in the early part of my second year of training, I was asked to join the faculty. And it was obvious that doing coronary bypass was not going to be good enough, that we identified aortic surgery as an area of personal interest for me and potential area of growth. And it was clear I needed more training. I was worried about it. Obviously, back in 2002, there weren't a lot of jobs in cardiac surgery. That generation of people at that time were still hanging on, for dear to the dear end, bitter life. And the older surgeons, even at Clifton, were holding on to the cases. Division chief was at a different site. There was low morale because of the volume. But there was no other jobs, and I wanted to do academic surgery. So I accepted the position. It felt right still, even though with all these concerns, it felt right. And, we didn't know how successful we were going to. I remember asking Guyton, I said, I don't hunt or fish, and, I'm not a good old boy. So how am I going to make it? He said, well, just, it'll be fine. And so I just, about 2006, my third year on faculty, I did this many surgeries, and I was the highest billing surgeon at the time and doing the most complex cases. And so in 2007, I was asked by the Society of Thoracic Surgeons Resident Association to give a talk on how I found success in cardiac surgery. And these next few slides are directly taken from that talk, because even today, this is sort of how I approach things. So it's about how you approach the patient, yourself, the referring physicians, support staff, introducing changes in your system. So I think the key is to really work hard and care about the people you operate on. I think if you work hard and care about the people you take care of, you will be successful 95% of the time. No matter what I did in academic surgery, the foundational vehicle upon which I was going to launch that career was going to be being a great doctor first. It was always the patient comes first, and no matter what, I was going to be a doctor. And so let me give you an example of what it really means for the patient to come first. So this is a 53-year-old guy. We did a hemiarch root on him in 2019, but he was admitted 3 months later with fever, chills, a bacteremia, and they had fluid around his graft, clearly a graft infection. And so, he had this, and then a week later, he had this sub-Q fluid collection that developed sternum. You can see it right here. This was not there a week before, all this fluid. And that was in the morning of March 4th. I was supposed to give a talk in Houston on March 5th. And then, that evening, he started developing, drainage from that. So what did I do? Well, I called the meeting organizers and canceled the case, or canceled my talk to operate on this patient. That's what it means, in my opinion, for the patient to always come first. So these are some cases I've done that I'm most proud of. And if you look at the spectrum of the operations, some of them are pretty routine, some of them are a little bit more complicated, but it wasn't the cases, it wasn't the actual operations I did, but who I operated on. And so, it just means a lot when, like, the echo lab asks you to do a cabbage on the father and uncle, of a cardiology fellow, the godfather of the TAVR lead cardiologist, people that would come from California, Lebanon, that surgery, a nurse's mom, the CNO's husband, the cardiologist himself, this means that you can't hide from these people. You can go to a national meeting and you can really be well known, but it's the people that are back home that really know what you're like and whether you care about patients. So when I get asked to do this, it just means a lot to me. So in any event, so I think that as a surgeon, I always want to, you obviously start with routine cases, but you're never afraid to take on the tough ones. And certainly at that time, we had to. And I've certainly known colleagues that never took on tough cases, and they just kind of stayed the same for the 20 years I've known them. But it's important to know your limits and be humble, seek out advice. One of the things I always teach the residents is you just want to stay right on the edge of anxiety. If you're not comfortable, if you're completely comfortable with everything you're doing in cardiac surgery, you're not learning at all. Unfortunately, in cardiac surgery, or probably any field in medicine, it's only when something goes wrong that you learn, if you're willing to own your part and grow from it. But, obviously, as you know, in today's world, it's better to be positive, avoiding negativity, drama, things of that nature. So, working with referring physicians is you have to, you don't want to be a complete self-promoter, but you have to be somewhat confident and do it very tastefully. And I think that it was very interesting that I learned very quickly that your work will do your talking. You don't have to say anything. Sloan and I have been at, all of us, Clifton, we've been at meetings where people tell about all the cases they've done and how long the cross clamp times were. Nobody cares. If you're a good surgeon, all that will be spoken on your behalf. But, you always want to communicate with the referring physicians. And I always learned that, you never say no when someone asks you to accept a patient. And I learned from Dr. Craver that this is really a business. And so I think it's important to treat it like such. And, there wasn't a lot of marketing back then by the institution I worked for, but so a lot of this word of mouth got spread, but just at a very grassroots effort. I think it's important to treat support staff with respect and courtesy. You're always under the microscope, and I think gossip travels faster through cardiac surgery circles. It's faster than light. And so it's just, everything you say, we know what goes on. We know what every surgeon in this country is doing and if they're prominent and what's going on. And so people constantly talk. And so, it's just something to keep in mind. And I think it's important that, you don't necessarily change the world overnight. You chip away at it. And that's something that was the saying that I had with my staff office assistant. And you got to measure your success in terms of months and years, sometimes days to weeks. You don't feel like you're making progress. It's only when you look back in time that you feel like something's done. But it's always an ongoing process. So, so I was at Emory for 10 years. And then in 2013, there was increasing constraints in cardiac surgery. We were losing OR resources, including staffing, ICU, and we were competing with our transplant team. And so that was becoming challenging. And the decision was made by the healthcare leadership at Emory, along with division chief, for me to move to Emory St. Joe's, a newly acquired hospital in the system. We were supposed to start 7 months later, and I remember thinking, God, how am I gonna do that, and so forth, and how am I gonna make all that happen? Taking these kind of surgeries to what was traditionally been a community hospital. And really the key is just communication. I think we had a lot of meetings about our needs and expectations. We didn't assume anything, paid a lot of attention to detail, flexibility about adopting to the new system in place. There are things that we wanted, but at the same time, they had done high quality cardiac surgery, so we wanted to adopt and learn from their system, and educated the nursing staff, the perfusionists, always available to educate. And I think really what all that means is that we were kind of rebuilding our team there. And we were very successful. I think in the first 6 months after I got there compared to the last 6 months at Clifton, our results were actually better. In terms, we did the same complex cases. We looked at the data and we extubated patients. The rate of early extubation was a lot better, and other things were a lot better. So it worked out well. But, so you think about what does the team mean? This definition has really evolved for me over the years. When I was a resident, I think I just looked at it as like attendings, residents, or PAs on the surgical team. But then I came to appreciate later on that really it's your nursing, anesthesia, perfusion, ICU. But what about the hospital leadership? Well, I think it's the entire hospital, quite honestly. And so I think everyone's striving toward a common goal of delivering the best care for patients. When I was a kid at the university, my dad worked at the University of Georgia, and he always I knew the environmental services person. Like I knew him by his first name because my dad would always talk to him. And so this is a lesson he taught me early, and I just happened to find a little thing on it on the internet. But I think that what really is that everyone matters. You think about the person that cleans the OR room after the first case. If they don't do a good job or they leave a little blood hanging around, the next patient could get an infection. And so everyone has an important role. Or if the lab tech person, processes the blood gas wrong and it leads to some inappropriate therapy, everyone really matters. So, I want to switch a little bit now to speak a little bit more in the medicine, but cardiac surgery has meant a lot to me in my career. It allows you to exercise multiple skill sets. You've got to have knowledge of anatomy, physiology. You got to be good enough to technically do the operation. You have to exercise critical care, and you got to have a fundamental knowledge of medicine, but it allows us to have a very positive impact on someone's life. And with a lot of patients, you can connect with them on a human level. It's very fulfilling and rewarding. It's meant a lot to me that a lot of patients who I've done surgery on in the past, even though they don't need any more surgery, but they just need their aortas followed, they still travel from Atlanta to Durham for me to see them once a year and get a CT scan. So that just means a lot. We collaborate across multiple subspecialties, cardiology, anesthesia, critical care, but there's a lot of opportunity for advancement and innovation. And if you think about adult cardiac surgery, what's happened in the last 25 years, we can do coronary bypass off pump valves that are now repaired that were formerly replaced. There's a lot of advances in mechanical support. There's increasing operating on increasing complex patients, low EF, older patients, bigger operations, redos. Mortality is all-time low. Catheter-based therapy, robotic surgery. So I apologize, I didn't put robotic on here. It was not intentional. But in any event, so there's a lot. And how is all this accomplished? Well, research driven by clinical needs, being bold, being honest, using data to drive quality, collaborating towards quality, participating in healthcare, but always remembering that the patient comes first. And so, to get there, you got to sort of provide care at the highest quality that can exist. You got to provide great service to your physicians, both inside and outside the institution. I mean, most of the physicians I worked with came from outside the institution I worked with. You got to build high-functioning teams with mutual respect, safety. You got to turn all that into great, either teaching or scholarly pursuits, and you got to pursue excellence in each of these endeavors. And excellence in surgery is caring about your patient, having good knowledge of their problem, being precise, attention to detail. Every part is important, making every movement count. It's a team sport. I think it's very cliche, but it's really true because, there's 8 people or so in the OR and it matters. And then it's not just done when the surgery's done. I mean, there's a whole ICU team. And then it's always about follow-up, observation, correlating, owning your problem. So I think for me, it's a lifetime process. Always striving to improve as a surgeon, whether it's outcomes, pushing the envelope on what's possible, advancing the field, never knowing where it really is going to end. And I think that, the residents that work with me, like in 2005 versus 10 versus 13, they each have a different experience about how we suture things, the needles we use. And so there's always ongoing, evolution. So I want to switch and talk about one area that I try to pursue excellence. That's, aortic root replacement. Typically, if you have an aneurysmal root, you would excise all that abnormal tissue, sew down a valve conduit, reimplant the coronaries here. And, 20, 30 years ago, there was only mechanical root options, but now there's a lot of different options. There's, tissue valves, mechanical, there's homographs, all, they pre-made conduits now. But the problem with all those things is that it's the valve. The valve is replaced. And if you, depending on if it's a mechanical valve, you might be committed to a lifetime need for long-term anticoagulation. Or if it's a biologic valve, the valve can fail. And there's also the issues of endocarditis with these valves. And, valve sparing root replacement, I'm sure a term many of you heard, is an option where you can preserve native valve function or improve it, typically applied in the setting of leaky valves, AI, not stenotic narrow valves. The aortic leaflets, cuffs have to be normal, and only a small percentage of these patients really candidates for repair. But this is what valve sparing is. The same root aneurysm, valve is attached, and then there's two ways to do that. There's the reimplantation technique where the whole valve apparatus is inside the graft and the coronary buttons are attached. And then here is a remodeling where there's the graft is scalloped and sewn to each sinus segment. And there's a subtle differences between the two, but that's kind of what that is. And just kind of made simple. So you've got the valve cut out, or the root aneurysm taken apart. This is the right coronary, left coronary, tri-leaflet valve, rim of tissue here. Then you test it, and it coaps really nicely. Looks like a Mercedes sign. Leaflets all look good, not much calcium. Then you take this graft and kind of, alter the dimensions as you see fit, not to get into the technical details. Then you kind of bring this down to the base of the heart around the graft with some sutures. Then the valve is inside here. And so the root's been replaced, but the valve function remains. And so what have we learned? These are technically difficult procedures. You got to really understand aortic root and valve anatomy. You got to recognize abnormal components, have to have enough judgment to do the appropriate techniques. And you got to have enough skill to do the operation. It's still a little bit of art more than it is sort of science, so to speak. There's a lot of potential for morbidity. Are you going to do a bigger operation? Is it going to be safer for the patient? It's going to be durable, especially will the valve remain competent over time? So you got to make that choice very carefully. Typically, in the beginning, it was done with root aneurysms, normal leaflets, elective surgery, minimal AI. But over time, people started doing them in dissection, redos, a lot of AI, older patients by custom. This is a whole completely different topic, and we've embraced all these indications, and we're one of the, we were sort of one of the leaders in doing it in North America for dissection. And so, here's the next few slides. I gave this talk last May at the ATS on who should not have a valve spring. How do we decide? And so there's three important factors on how do you decide whether to do valve. There's the surgeon and that person's experience. But anyone who knows a cardiac surgeon is not just experience, it's ego, and then there's the patient, there's the valve, cuss quality, amount of AI. And the last thing, but not only AI at baseline, but after you come on bypass. And then there's the patient and, how old they are, other medical problems, how long they expect them to live. This is the guidelines, the latest 2022 aortic guidelines. And really what I want to point out to you here is that it says that in people needing root replacement, valve sparing is a 2A indicator, is reasonable if the valve is suitable and when performed by an experienced surgeon. But the problem is that there is no validated number that defines experience. So a surgeon really has to be honest with herself, himself, themselves as to if they're able to do the surgery. I've had colleagues that wanted to do the surgery and they've done one, and it was back in 2005. It just became sort of a hot thing. It's almost like you had to do it if you stayed relevant. But here is a table on my take on experience and ego, assessing surgeon experience. If you got no experience and no ego, if you're a new person out, but you're humble, sky's the limit, but the learning curve is steep. If you got no experience and a lot of ego, I feel sorry for your patients, man. And then if you got a lot of experience but no ego, that's who I would want to be my surgeon. And ultimately, if you got ego and experience, if you got good outcomes, I guess it's okay to be a little egotistical. But in any event, assessing valve quality, these are the views that are most important. The short axis view without color, which determines cuff quality, opening and closing motion, how symmetrical they are, the free margin lengths, and then any signs of degeneration on leaflets. Long axis, so when I do a case, in the OR, we're looking at short axis without color, long axis with color, because you're assessing the nature of the AI jet. Is it central or eccentric? That's all you want to know. Because if it's central, you can typically say that doing the valve sparing, bringing everything back together is going to work. But if it's eccentric, you may have to do cuss work to repair, eliminate the leak in the valve. But assessing cuss quality, other important views are short axis with color, especially when you come out bypass and there's AI. This is kind of tells you where the leak is. And long axis without color can detect cuss prolapse and confirm the EI. See here, you can see this cuss is prolapsing. Typically the leaflets should look like an iPhone prayer sign, but it's not quite. That one is not, this second hand, so to speak, is flopping downward. So it gives you, a good assessment of what it's going to be like. But no matter what is shown on the echo, intraop visual inspection and assessment of the valve trumps TEE. So this is kind of what it should look like. What you want is a 3 leaflets, relatively symmetrical opening, closing. They look like there's the leaflet free margins are relatively thin, not a lot of calcium deposits. The length looks relatively the same. And, this is kind of what you want to see in real life. And sometimes it's depending on the geometry of the root, it's hard to get that straight on look, but this is one that looks potentially sparable. Now this one here was not so good. This has got some calcium buildup, asymmetrical. This was a sort of a partial fuse bicuspid that could be misnomer is a trileaf, but this calcium buildup here, and it may not make this one sparable. And so, ultimately, assessing the leaflets, you want to look for degeneration, fenestration, symmetry, all these things, prolapse, free margin length, and all that. And when you have cuss prolapse, it's okay if the free margin is elongated because you can shorten that and get rid of the prolapse. But if it's shortened, there's not enough leaflet there to make it work. And so one of the things I always try to teach the residents is you want to really recognize the anatomy that the valve displays for it to work after surgery. So you want it to look like this, where this is a suction just to kind of create a vacuum in the LV, 3 cuss, no prolapse, good coaptation. That's kind of what you're looking for. But AI and the AI jets, and where the centric, eccentric, there's varying degrees of difficulty of doing that. So here's another one of these 2x2 tables. A tri-leaflet valve in AI, usually doing the valve sparing alone is good enough. A bicuspid valve central is not very common because of cuss asymmetry, but typically that will work as well with just valve sparing. Sometimes maybe a cuss repair may be needed. An eccentric jet, this is typical. This is the most typical situation for bicuspid valve, but this is not too bad because there's only one line of coaptation to consider, with the leaflet, making them symmetrical. But it's the tri-leaflet with eccentric jets that is most difficult because there's 3 lines of coaptation, each of those lines of the Mercedes sign that you've got to continue. So when I think about, addressing AI, there's 2 ways to root broad categories. It's altering aortic root geometry. Whether you do the valve sparing, how you orient the commissures, whether you narrow the annulus, which is what we mean by annuloplasty. Then there's cuss repair, which is typically free margin plication, which is not necessarily at the center, and then resecting any part that's a little excessive. This Gore-Tex suture thing is where they weave a suture along the free margin, but you can't really control precisely how much free margin, how much shortening you can achieve. So I don't think people use this as much, but this is sort of the broad category of that. And just want to show you some examples now, of these. This is a tri-leaflet valve with central AI. You can see the jet goes straight back. Here, there's a gap here in the middle where the leaflets are not meeting, and ultimately just doing the valve sparing alone can eliminate that leak, and you got good coaptation, not much leak at all, and the leaflets sort of open a lot better. Now, this next one has eccentric AI, and you notice here in the middle, this cuss is prolapse here. And you can see that on the echo, and then because it's prolapse, the jet is going away from it toward the anterior leaflet of the mitral valve, and then you can see a lot of lack of coaptation here. But then you look here, this is the anterior leaflet. It's the right cusp that's a little elongated. You see how, you notice how this bottom one is a little floppier than this left and this non. These two look the same, but this one is a little longer. So you can go in there and kind of do the valve sparing and plicate the right cusp. And it seemed like it was better there and make it work. And then this one, we had a little bit of AI here at the end, but overall, it worked out pretty well. So just a couple of things. This is two more examples. This is a sparable valve because this AI, eccentric jet, and both going to the anterior leaf of the mitral valve. But this one, you have a floppy right coronary cusp that's prolapsed, and the jet is going away from it and so forth. Here, you've got this left cusp that's a little restrictive. You see, it's a little shorter. It's a little more, it looks more taut, like a tighter bowstring than this non and right. And because it's restrictive, on its posterior, the jet is going to go away. So that's the kind of nuanced appreciation you have to see these things in the OR. And just to kind of show you a little bit of some of our research, we looked at looking at eccentric jets and see whether they impact outcome or not. And I think here we show that, freedom from AI or needing didn't really get impacted, whether it was a bicuspid valve, trileaflet, or eccentric or concentric. And these are all patients that had mostly 2+ AR higher. And then same here, whether it was bicuspid trileaflet or eccentric trileaflet, there was not much difference in the freedom from needing an AVR. And so the last thing I want to talk about is residual AR. When you take the clamp off and there's a little bit of leak, it's inevitable, happens to everybody, and it just, what are you going to do about it? So here, this was a case. This is the baseline images. It looked like a relatively symmetrical jet, maybe a little sort of a different eccentric component, but trileaflet valve, you can see here, lack of coaptation. And when we took the clamp off, we get this, we get this 1 to 2+ jet, and you can look on the short axis, there's a little bit of leak from the right non-coronary cusp, and the question is this, so for me, this is not good enough. A- is not good enough for valve sparing. It has to be A or A+, because over time, I think it's been shown that this will, lead to early AI. So ultimately what we did was we went back on, and then we plicated that commensurate with the right non, did a subcommissural angioplasty, and because the T had showed there was lack of coaptation right along that post and so forth. And this is what it looked like we took the clamp off, thank God, because these cases are actually more fun in retrospect. They're really not, for me, not that fun going through it, because you just don't know till you take the clamp off, and hours have gone by. So I think just not to get too technical, but when you have AI, you got to make a decision. Are you going to clamp, or are you going to decannulate and move on? Or are you going to repair or replace? You got to really have good judgment here, because it's all relative. Because if you go from 4+ to trace like that one eccentric, you feel good. But if you go from 0 to trivial to 1+, maybe that's okay, but you got a lot to learn still. And this is just never a good feeling when you have a young connective tissue patient that has 0 AI and you go to trace or mild. It's just not a good feeling. And it's happened. It happens to everybody. AI in a new location, that you got to have really good judgment here, on what to do. So just a couple other thoughts, on patient-related factors. The ideal patient is going to have a 10-year or greater life expectancy, no significant organ dysfunction. And I just want to focus on doing the outcomes in these types of procedures, reoperative surgery or type A dissection. This was a paper out of Japan where they looked at valve sparing over 65, valve sparing under 65, and Bental over 65. And they showed that freedom from AVR did not matter. Whether you had valve sparing or not, or Bental, almost a different survival based on age, not quite significant, but, not surprising given the age difference. But it's interesting, the valve sparing patients in general did better than the Bental patients, because those patients are selected, they're very selected very carefully. So in my opinion, the older the patient is, the better the valve has to look for you to do that. Because when you're 65, you could put a tissue valve in and it'll probably last 10, 15 years and do a TAVR. And so so the only reason you would do this kind of operation is really if the valve were to look really great. So, and just to finish up, for dissection, the cusps usually aren't that degenerated. The AI is because of the dissection process and prolapse of the commensurate post. The buttons can be friable, but it's not really associated with worse outcome. And we've written about that. And really, it's not necessary. You don't want to do it in someone that comes in with shock, organ malperfusion, a lot of extensive cusp repair, or any surgeon inexperience. And the last thing is, is it justified in redos? And this is a Germany, the Hanover group, looking at patients that had valves, their survival after a first-time case versus a redo. And in any event, not only survival, but freedom from reoperations, really not significant. And they concluded that it can be done in redos without compromising late outcome. But you got to select the patients very carefully. Lastly, so to conclude, I think an excellence, professional growth, it drives innovation, advancement, especially. It's a lifetime pursuit. You got to really have an innate desire to do the best, always do the right thing. You want to teach the next generation to be passionate and always humble, because no one's in this room, no one's education is really ever completed. We don't know what the pinnacle is. Thank you so much.
Ed, great talk, and thank you for sharing with us your core values, your philosophy, as well as teaching us quite a bit, and actually a very complicated topic, but very clearly taught. I guess my question to you is, when you look at those, dilated aortic roots with aortic regurgitation, if you look at the denominator of patients that have that problem, what percentage of them do you think today can, in good hands, undergo valve sparing operations?
It's very low, Habib. Even the most, like I used to do 80, 90 routes a year, and only about 20, 25 of those are valve sparing. So, but I'm very selective too. And if you look at like Tyrone David, who invented the operation, the reimplantation, which is the most common technique performed, he's been doing the surgery for 30 something years. His series is like 400 and something patients, maybe close to 500. So there's not a lot of those patients that need the operation, quite honestly. And it really has to do with cusp quality and probably some, in the patient himself. So I'd say probably, 10, 15, 20%. I don't think we've ever quantified that exact percentage, but it's very low, to be honest.
Yeah, and I'm kind of curious. I know we're going to show a couple of cases, but if you look at patients with bicuspid valves and aortopathy, for instance, and that's a pretty significant group, right? You've got the senile calcific valves and the bicuspid valves. What about sort of the advent or the impact of transcatheter approaches versus surgical approaches? Obviously, if you've got a very large aortic root, it's going to lean more towards surgery. But what about just patients without very, very large roots? In your mind, what is the algorithm, or what's the team that needs to evaluate whether an aortic valve is approached surgically or through transcatheter techniques? Yeah,
they talk a lot about the heart team concept and lifetime management of aortic valve disease. I don't think we really have the answer. I think you can at least broadly categorize them into AI versus AS. With AI valves, obviously repair is probably a good thing, because you can leave some with a native valve that could last, forever. We only see the numerator as a surgeon, but we don't really truly know what the denominator is. So I think if it's an AI valve, we try to repair it. And that's a whole nother lecture there. But with AS, I suppose it has to do with, I think you have to involve the patient in these things, lifestyle considerations, desire to, or willingness to be on anticoagulation or not, overall comorbid conditions, things of that nature. And also age of the patient and what decade of life they're in. But I don't think there's a real formula for that, or sort of a algorithm where there's very easily like branches of thought, but I think I think each one should be individualized and I think, I don't, obviously the bicuspid TAVR experience is now growing. So I think we still have yet to see what's going to happen. My biggest question is, are those valves going to last a long time in a young patient and so forth? And some patients are okay with mechanical valves. They don't ever want to have another intervention, but some just don't want to deal with that. So it's hard to say. And it's very interesting too that the PPM, nobody ever really cared about PPM 15, 20 years ago. Like people put in 19, 21 valves, but suddenly with valve TAVR, people start caring about that. I remember like we tried with one of our fellows. Oh, it's patient prosthetic mismatch. It's when the valve, based on the size of the valve, is too small for the patient based on the patient's BSA. So it's the orifice area of the valve over the body surface area of the patient, and under 0.65 is considered severe, and moderate is between 0.65 to 0.85, something like that. But in any event, I think people, like I remember one time we tried to submit a research project to the Society of Thoracic Surgeons, and with one of our residents who had interest in that, and they totally turned it down. Next thing you know, 3 years later, when TAVR comes along, all the society leaders are doing that trial and on the paper. So it was very political. So the best I could do is get the resident to be a co-author on that paper. But it's just interesting how life interests change over time. Sloan.
Ed, that was an incredible talk. I mean, one of the best talks in our specialty that I've ever heard, quite honestly. One question I have for you is, what is the future of transcatheter aortic root replacement? I know I'm aware of a couple of cases where they've tried to do that with, coronary revascularization, basically TAVR and TEVAR in the root. Do you think that procedure is going to be available in the foreseeable future?
I know there's a Murdoch Goreshi at Maryland's done 5 of those cases, and I think Brad Leschnauer maybe have done 1. It's going to have a role. It's important. Some of these type A's that come back with a root aneurysm and they got AI. I mean, yeah, you can do those cases, and most of them can do pretty well, but there's a few that, man, you don't want to do that. I think all these technologies will allow us to expand the spectrum of the patient population that we can appropriately treat. Just like with TAVR, and we talked about that recently, redo AVR after CABG, we can get them through a better quality of life. So I'm all in favor of that. As I was not sort of put on the TAVR team years ago, so I've not done a lot of those types of things, but I do think it will have a role. The coronary button anatomy for me I don't think the valve implant's going to be an issue. It's the coronary button anatomy, because, some of these root aneurysms in the coronaries can be quite high, they can be low, they can be right next to the annulus. It's highly variable, and you can't really appreciate on cath or really on a CTA of coronaries where they are. So I do think that that's going to be a challenge, and I mean, it's certainly something to really embrace, I think, to be honest.
So actually, Dr. Guy and I had just a couple of cases we were going to add here just so we can get Dr. Chen's insight. The first patient is a lady, actually, they called me at 5:30 this past Saturday. She's an 82-year-old female. You can go to the next slide, or do I need to do that? Yeah, right here. All right, here we go. 82-year-old female. She basically showed up to the ER with a blood pressure 220 over 105 and had, on that same day, the acute onset of back and chest pain. She actually had been having chest pain for several days and had a hospitalization on 3 weeks earlier where she appeared to be septic, but had an interesting finding that she had a pericardial effusion. She had no AI, the EF and remaining aspects of the echo were normal, and she did not seem to have any cardiac ischemia. She recovered from that and went home pain-free, and then had repeat onset of this chest pain when she had this severe aortic, had the severe pain. So this is a running CT angio of the, it's actually, you can see this is actually a pulmonary CTA, but the timing was such that we could actually see multiple areas. She actually has an area of hematoma pretty much throughout the entire ascending aorta as well as descending aorta, has some areas of focal either dissection or ulceration. So this is one of those patients that's not your typical type 1 aortic dissection where you see the tear just above the torn areas and it extends all the way through. So I just wanted to get your insights as to when we have these aortopathies. This lady's 82. She was a DNR, and her family elected to treat this medically, which she's actually tolerating fine. But if she was 62, how would you approach this from your perspective?
Sure. Well, for me, a type A IMH is a variant of dissection. And, the dissection, just for those who don't know, is where there's a tear in the inner layer and then blood sort of separates the inner and outer layer. You get active blood flow between the layers. That's called the false lumen, whereas the true lumen is where it should be going. In a type A hematoma, there's separation of those layers, but there's clot in between the layers as opposed to active flow. Although you do see on the cut here, as the CT scan comes down, there's a little bit of what looks like a classic dissection right here. You see that? That's what it looks like. So there may just be a little active flow there. But, there's a difference in the literature, whether it's Western literature versus Asian literature. In Asia, medical management has been shown to be just as good as surgical management, i.e. replacement of the proximal aorta, whereas in the Western literature, including international registry aortic dissection, the surgical outcomes are better than medical outcomes. There's a couple, but at the same time, in someone who's 82, I think that they got to be a good candidate for, even though they have an acute problem, they have to be a good candidate. Because first of all, you think about the fact that a dissection mortality across the board is about 18, 20% nowadays. And then you add the age and maybe other frailties, that you may be talking about a 50 or 60% mortality, even though we don't necessarily have enough data to quantify those things. And so I think that whether I operate on someone like this or not is based on, first of all, whether I think they could get through the surgery and go home. It's not good enough just to get through the surgery and go to LTAC. That's not a victory for me. It's going home without a peg tube, without a trach, without a dialysis catheter. That's where the real victory is. So if I'm not confident about that, I wouldn't necessarily offer them surgery. But in this particular patient, there's a couple, so if she's frail and all that, I wouldn't do surgery, but she's got this pericardial effusion, right, which is, worrisome, but you can do serial imaging to see. But in someone who's 65, who we think can tolerate the surgery, for this one, without any significant arch pathology, I would do an ascending hemiarch under brief period of circuit arrest. I wouldn't reimplant the great vessels, and then I would just treat it like a classic dissection. And in the sense that's the operation I would do, unless it was arch pathology or root pathology. So
it's got a little bit of a dissection in the descending as well when you get down to
there.
Those areas that at a later time
you can just follow that and just endovasculate later if you need to.
So the next case head is a 35-year-old male who had a 5.3 ascending aortic aneurysm, and I believe that had grown by about 0.4 centimeters in a year. And had a strong family history. Sister had died at a young age of a ruptured ascending aortic aneurysm, as best we could tell. There was a high suspicion for Marfan's or some sort of connective tissue problem, and hypertension under variable control. This was the aneurysm, so it had that sort of Marfan type appearance on 3D, but it wasn't normal diameter up to the arch. It was maybe 4 or so centimeters, and a trileaflet valve. Yeah. How do you use the pointer here? That green button. Okay, good. Okay. Well, this is the heart. This is the this is the aorta here. This is the aortic root, ascending aorta, the arch here, and the head vessels. And so this was, this is clearly dilated. This is not completely normal. And, I really I don't know how you feel, but I really like to look at it both 2D and 3D. It helps me sort of visualize how we're going to see in the operating room. And, this was the echo. So not a large jet, looked fairly central. You can see the measurements there. And so I thought this was especially given the age, this was a reasonable candidate for a valve sparing route. What are your thoughts about that? First of all.
Yeah, I agree. Just to educate the audience, the traditional guidelines have been 5.5 centimeters. But there was a paper written about 4 or 5 years ago from Yale the original guidelines in 2010 are actually based on only about 232 patients out of Yale. And that's led to the European guidelines, Canadian. But that database is now up to 3,300 patients and from Dr. Lefteriades, and he has done some additional granular work. They looked at that data more granularly, and there's two sizes at which there's a abrupt increase in adverse outcome: 5.75, which was, we originally knew that, and 5.25, and so so now he sort of proposed a left shift whether we should operate at 5 centimeters or not, and but that's only one paper that's talked about that. And so now the guidelines say 5.5 still, but they say 5 to 5.5 if it's an experienced surgeon or a patient or a center of excellence. And one of the things they talk about is that patients, if you have a family member die of a dissection, you should have surgery, or a rapid growth, which is 0.5 centimeter in 1 year, or 0.3 millimeters a year for 2 years. So this is 0.4, which is almost 0.5, family history of dissection. He's young too. And that's the other thing. When I tell patients, I think about things, I think, relative youth is a reason to consider between 5.5. When it's 5.3, when you're 21, it's a lot different when you're 81. Certain occupations, a pilot, fireman, they don't get cleared to work unless those things get repaired. Chest discomfort, family history, growth, or sometimes anxiety. Some people can't sort of move on to life without it. And I think that's okay to do. Extreme levels of activity, Ironman, triathlete. These are all the reasons that I discuss with patients when we should operate. But this one with the 4.4, the family, especially with the sister dying, I think that would benefit from surgery. And you see the valve, the echo shows a little bit of leak in the valve. And so, that leak over time can cause a cuss to be, sclerotic. And so better to do that now than later.
I think one thing that we struggle with in clinic with these aortas is that decision whether to operate or not. And we have our office team here, and we see these patients, and we struggle with a couple of things. One is the variability in measurements, because it seems to vary. The radiologist, of course, will say one thing, we look and say another. So there's variability within measurements. And then also, the guidelines changed. And, I used to look at the diameter to body surface area as a something I could hang my hat on. But then the aorta height index came up. What do you really hang your hat on when you decide to operate or not, independent of the other things like family history, et cetera, just purely based on size?
I've not tended to, unless someone has extreme body habits, like very petite person or very big person, I have not used those BSA height things. I mean, I can do the calculations, but it's mostly just the size and having that discussion with the patient. My father, a year into my time as a faculty, was diagnosed with ascending, 5 centimeters. We just chose not to operate on. He was 71, and that over the last 20 years, that's caused me to be very thoughtful about who I'm doing surgery on. So, I've got some surgeons that we know people that no matter what, 5 centimeters, we just do surgery. I just don't think that that's necessary. We don't need to do that. I think it's important to have a thoughtful discussion. Talk about the pluses and minuses. There's nothing we do in cardiovascular medicine or medicine is without risk. And there's data now talking about circ arrest and how there's, MRI lesions that are not diagnosed clinically or some, some of the studies that Chad Hughes is doing, looking at circ arrest can cause the gray white matter ratio to change or something like that. So I think that, I just have that discussion with the family and don't tend to use those other measurements. And sometimes you operate on these patients and the aorta is really thick, but then sometimes we operate in 4 something and the aorta is really thin. So there are a lot of factors we just don't appreciate outside of size, but that's the most common thing we have.
The most stressful part of that decision for me is it's all well and good until there's a bad outcome.
That's right.
You end up with a patient that dies because, it's 1 to 2% mortality. So somebody's going to meet that end, and it's a prophylactic operation. The patient's pretty okay when they come to your office. And so that's, I think it's a tough part of the business is who to operate on and who not to.
You know, a lot of patients have told me this. This is why I'm saying a lot of patients say, well, if you don't do that, you're going to die. Well, we're all going to die. No one's getting off this planet alive, you know? And so I think, I think it's just, the other thing I use is, this is not a used car dealership. The deal is not going to go away. Go home, think about it. And I always tell patients, if you don't know if you should have surgery, don't have surgery. You should only have surgery if you're absolutely sure you want surgery. If you're not undecided, just keep thinking about it. And I always say, I'm not here to tell you what to do, just provide information for you to make a good decision. So that's how I've kind of approached my patients over the years. You know?
So what we did in this case is I did a David 5. I did a David 5 reimplantation with 3, for the surgeons in the group, 3 subannular sutures, sort of Ducameron style, and used a 26 Valsalva graft based on measuring the height of each of the leaflets and divided by 0.7 and adding 3. That's kind of an algorithm that Joe Bavaria that trained me had come up with. And then we did the ascending hemiarch with a 24 graft, which is a little smaller than I'm used to, but it fit, it seemed right. And, I was a little nervous about putting a little bit smaller graft on. The other thing that we did that is a little bit novel is the head circuit, and I thought I'd highlight that a little bit. So I learned this from a private practice guy in California, Vince Gaiani, who was my mentor, and he was a big believer in antegrade cerebral perfusion. In other words, not stopping blood flow to the brain while you're circuit resting the body, and also of not having a prolonged rewarming period. So what we do here is we'll put a 12 or 14 French cannula in the innominate artery and put basically a bulldog on the base of the innominate artery, a separate cannula in the arch, and we'll cool the head to roughly 20 and the body to roughly 30, and then circuit rest the body, do the arch with the head continually perfusion. And usually head saturations are maintained. And what we found is that this allows us to rewarm, and a little bit different from the Emory protocol, which probably has the most publications on moderate hypothermia for this, is that we're cooling the brain a little bit more aggressively, which, gives me a little bit more comfort level. But this has worked pretty well, and we did that in this guy, and it didn't really, there really was no rewarming time. When we were done with the root work and the graft to graft, we were done. And the patient did reasonably well, had a good result, and no significant aortic valve regurgitation, and has done fine clinically. One question I have for you, one final question is on the subject of subspecialization, something that I've struggled with. I've done, you and I, we actually finished training the same exact year, I think, 2004. Yeah. And so we were trained to really do anything from heart transplants to lung transplants to aortic surgery, whatever. And, at some point, I was taught you have to kind of focus. So, I try to focus on mitral valve surgery, et cetera, but, I still do other things. And, because there's no way I can be as good as you are at a valve sparing root when you're doing a lot more than I am at them. And what are your thoughts on subspecialization versus general cardiac surgery?
I think it should be somewhere in the middle. University of Maryland, Jim Gammy, when he was there, he wanted everyone just to do mitrals or whatever. But I think it's important for everyone to be the it person in something in cardiac surgery. That's something I learned from Robert Guyton. But you had to build overlap expertise in the system. And really, I don't necessarily want to do all these cases all the time, so I'm glad that there's people like you that can offload those things and have expertise. But I think, having everyone focus on something they're particularly interested or passionate in, but having other areas of expertise can only make the team stronger. And then, you just kind of have a team where everyone kind of has their thing, but there's overlap and redundancy of expertise. And I think ultimately that keeps the system less vulnerable in case, something were to happen with personnel transition or things of that nature. So, somewhere in the middle, I think is okay, to be honest. I don't think it should be, it shouldn't be at either extreme, to be honest.
Well, thank you so much. That was a phenomenal talk, and we're honored to have you. Thanks so much.
And my dad is be 89 July. He never had surgery. He's still doing fine. It's like 5.3 centimeters. So anyway,
he's okay. Thank you.